So I'm going to attempt to do the impossible in a half an hour, which is to talk about everything through the issue of pain. Pain's a very interesting issue, and the studies that have been done on pain, the amount of money that's going into research on pain, it really gives us information that runs across the whole gamut of how the human being works under stress, and how we get caught in dilemmas. So let's start first with a definition of pain. So all of you understand that if you put your hand in the fire, that won't be long before there'll be a very quick urge run by your spinal cord to move your hand out of the fire. And by the time that piece of information's got up somewhere into your brain, you're going, ouch. And then you might be calling yourself names and doing other things on top of that. That process is what everyone thinks of as pain. However, once pain's been around for a little while, it doesn't work like a simple line as a neurological line. People are stuck with the idea that pain is always neurological, and it isn't. It's not always mediated by nerves. There are a lot of other mechanisms inside the body that create, perceive, and express pain. And we'll get to those in a little bit. But first, let's talk about chronic pain and the difference between chronic pain. We have lots of trouble defining pain. People are still arguing about it in the International Pain Journal about what pain is. Everybody knows what it is, but no one can really give us a very strong definition. And then when it comes to chronic pain, the definer is it's been around for longer than 3 months. That ain't very scientific. It's not a very good definition. The reason we say 3 months is because in our clinical experience, somewhere around the 3 to 6 month period, the acute mechanisms tend to go away and are replaced by other mechanisms. And those other mechanisms I'll talk about in a little while. The inability for us to forget our pain. Now that's very interesting because the forgetting process is sort of one of the things, or lack of the forgetting process, is one of the things you're dealing with all the time when you're dealing with any trauma which is now brought into the current world now based in something that's happened previously. The inability to forget, and that's a simple word, but a complex process inside the body, is the center of what we are dealing with when we're dealing with people reliving loops over and over and over again of all sorts, whether it be an anxiety disorder, PTSD, or in this case, pain. So let's go back and look at first at the idea of what gives us the idea that pain is not simply a nerve. There's a condition called post-herpetic neuralgia, and post-herpetic neuralgia is chickenpox that you get in later life, or once you've had chickenpox once, and if you've got immune difficulty, then one single nerve root gets activated with the virus of chickenpox, comes out in little spots, those spots break, they become very painful. And then that pain should go away once those spots are gone. And in some people it doesn't. And in fact, it becomes excruciating. It becomes that you can't have the sheet on it, you can't have any clothes on it, you can't have the wind go past it. And when it's cold, it's worse. And when it's hot, it's worse. And so it really is extremely difficult position to be in. So it's obvious that if this nerve that is full of the virus was cut, then the information wouldn't get to where it needs to go to be called pain, and the pain would be gone. That experiment has been done in the last 30 years and demonstrated very clearly that that's not the case. So that makes the case that there are other things working here that create the pain process in people that have had pain for a long time. Let me talk about the incidence of pain. So chronic pain exists across all cultures, 20% of the population. Half of that population limit themselves in some way because of their chronic pain. So that's 10% of the world limit themselves because they're in pain on a daily basis. That's a huge number of people. The fact that it's only now coming to be fashionable to talk about it is nothing to do with the pain itself, because people who are in pain are really, they're obsessed by it. And they're not good party friends, and they're not people you want to go out and have a drink with, because they're going to talk about their pain. And they're going to talk about their pain. And they're going to talk about their pain. So it's not interesting in many ways. The things that has made it interesting, the thing that has created so much modern interest in it, is the overuse of opioids and the problems that have come out of those opioids. When we got long-term opioids in the late 80s, we thought that we could use as much as the patient could tolerate, and ultimately we would stop the pain. That's turned out to be incorrect. The thing that opioids do is to stop a particular link from happening. But in chronic pain, that single link now is turned into a big branch. And as it's turned into a big branch, you're only stopping one link amongst the whole lot of the branches. And so you lose the effect of the narcotics over time. And in fact, you have all the problems associated with narcotics. So we no longer think of narcotics as the mainstay medication for these. I work in a pain clinic, in a tertiary level pain clinic. We spend a lot of time training people about pain, GPs, physiotherapists, and it's a full multidisciplinary team process. That is, we have lots of equal level of people apart from the doctors. We have nurses, we have educators, we have physiotherapists, we have psychologists. So we do that all the way across, and we talk to people all the way down to the South Coast in our case, through things like Zoom and telehealth. So it's a very common disorder. And the thing about it is that what seems to be happening is that one of the things that we think the brain does is start its day from yesterday. And the reason for that is because if we started from our infancy, we have a lot of catching up to do before we were functional in our day. So we make assumptions. Our brain makes assumptions that today is going to be something like yesterday. And that assumption, when it comes down to things like simple perception of things like pain and stuff like that, is one of the assumptions that creates the loop that continually gets us to feel pain and pain and pain and pain. So I'll ask you, well, I can't ask you this question. I would normally ask you this question if we had a feedback session, but I'm not used to doing it this way. So pain is one of those alarming processes. And because it's an alarming process, it takes charge of us. It takes over. It's supposed to do that. It's supposed to do that because you're supposed to bring your hand out of the fire, right? That makes sense. However, when there is no fire any longer and you're still having the pain, but you are dominated by it, you're in trouble, because it's the forefront of your thinking, the forefront of your perception, the forefront of everything. There are other conditions that do this, and you are dealing with those other conditions where other things become forefront to people's reality rather than living their lives, living it well and experiencing what's next and all the complexity of a life that a life will bring, because they're so caught in the difficulties of something taking over their reality. One of the things we're trying to do with chronic pain is find a switch that turns it off. Well, that's turning out not to be so effective. We haven't found one of those. We look for one of those. Is there a surgery? Is there a medicine? Is there something that's going to turn it off? And the reason that's not the case is because it's not a single switch. It's going to be a multiple switches. And the research shows that as many as 104,000 different changes occur within the brain of somebody who has chronic pain. 104,000 different changes. And that's a lot of change that's going on. And you won't get those with one single switch. But they are your brain. And like all complex brains, they are able to be molded and moved in a certain direction. That's back to the whole idea that there is plasticity. But there's plasticity in both directions. And if you move in the wrong direction and get stuck, then you're in trouble. If you move in the wrong direction, then pick it up and move it back again very gently and appropriately with the techniques that you probably know many, many of already. No different in chronic pain. We try to do exactly the same thing. The problem is that in chronic pain, people say, you are telling me my pain's not real. We never say that, right? We do, and they say it's all in your head. We say, well, it certainly is at least part in your head. But it may also be in the nerve root. It may be also in your skin. It may be in a lot of places. But you won't know where it is if you don't include your head. So things that help your head are going to help your pain. The other thing that's interesting about pain is the tracks that make up pain are very close to the tracks that create the other two experiences of being alarmed. And that is fear and anger. And fear and anger and pain are the three hardest things for us to ignore. Most of us learn pretty much how to mitigate and work with our anger. But if there's enough anger, it will take us over. Most of us learn what to do about our fear. But it is very difficult to do that when it becomes something which we define only as body, which is what we do with pain. And the problem with that is that once you've got pain, you then experience your body as your enemy, the thing that does to you what then disrupts your life and turns you away. And of course, then people get caught into this process. I need something to fix it. I need to find a practitioner. I need to find somebody who's going to turn my pain off, right? Now, sometimes it works. Sometimes some of the surgeries we do help. But, you know, when you're on your second or third surgery, not really. The most common pains that we come across, back pain and the pain of osteoarthritis. There are many others, but they're the most common. And back pain is basically the wearing out, or what's called the wearing out, but is really about age-related remodeling that happens because we use our backs in the way that we do. And osteoarthritis is really about the joints becoming, changing over time, and then us having to work out how to do that or work that out inside us. So one of the things that we will be doing in pain is teaching people what this means to them. What does this say about you that you have this particular pain? Sometimes we can't tell you. Sometimes we simply don't know. Other times we can say, well, you know, you put too much weight on that joint. You use it too hard, you push it too hard. You need to find ways to not do that. Or you need to find a set of muscles that will protect that joint better than what you do now. And that might be physiotherapy, might be rehabilitation medicine, might be using a cane. And it might be doing this thing that's very hard for us, which is learning how to pace. That is to learn how it turns out that people with OA, one of the things they need to do is to keep moving. But if they overmove, they hurt. If they hurt too much, they lay down. If they lay down, they become deconditioned. If they get deconditioned, then they've got no protection for their joints. Next time they stand up on it, they're going to hurt it and go and around and around. And that's not about the osteoarthritis. That's about what a person is doing with it. But at the other side, one of the things out, and people come back and they say, yes, I know all that, but I want you to make a difference to this. I want you to fix this. Because as long as it's the machine that's the trouble, then you get the mechanics to fix the machine. And of course, chronic pain is not just a machine. It's not just a problem in the machine. It's a problem in the person and the machine together. It's what you do with the pain, or what you do because of the pain, that becomes part of the problem. It's how you withdraw from, push against, argue with, find a magical reason, a magical diagnosis. And people chase all sorts of stuff in order to try and get the magic that's going to be infused into them or given them, or the one particular process that would help. And, you know, we don't mind if you find the one that works. We do mind if people are chasing and chasing and chasing, because we know that the chasing and chasing and chasing creates its own dilemma, its own process, and reinforces pain. It's a little bit like saying to you, I want you not to think about the carpet. Please do not think about the carpet. The first thing you do is to think about the carpet. Every time you think about the carpet, you're doing all the processes in your system that create the pictures, the thoughts, the mechanisms of the carpet in your brain. Every time you do that with pain, you reinforce it. So pain itself will be an alarming process, and you are reinforcing the alarmer. We talk about things like people getting used to the fire alarm going off every time you turn the toaster on, or the car alarm going off at 2 o'clock in the morning every morning. You know, at first it's startling, sooner or later you get to learn to live with it and work with it, and you work around it. And this is pretty much not unusual to a lot of other psychological processes we use. The thing about dealing with people with pain, even though they may also have PTSD, you can work with their PTSD, you can work with their other disorders, but if you don't include the pain will separate itself out, or the patient will separate the pain out and still have that as becomes their major problem. And they can't feel well, they can't feel all right, they can't become robust, they can't become integrated, they can't do the things that we're looking for people to do when they have something that keeps alarming them and takes over and over and over. But if you separate it and make it a psychological process, most people won't buy it. They're not interested. And when you say, look, this is made worse by your torture, your PTSD, whatever, they go, yeah, but how do you stop the pain? They don't really want to put those two together. And it takes a fair bit of real integrative processes to bring them together. And if you don't bring them together, the separation of them, in my opinion, will maintain both of them. There'll be a contest about which is going to make me more miserable, which is the one that's going to run my misery for the day or the week, because I go from one to the other to one to the other, from one to the other. So getting the integrative process going very well is one of the things we do. And most modern pain processes have pain programs. Now, what we mean by pain programs is they're training programs. They're programs in which we educate you about what's going on. We educate you about what the medicines will and won't do, what the nature of chronic pain is and what it's not. And certainly being able to say to people, this does not mean that you're going to end up in a wheelchair. What it means is your body interprets many things as pain now. And because it does that, you will feel pain. And it doesn't mean that you're going to end up in a wheelchair or forever in a less than situation. However, because the pain is so extraordinary and takes over your awareness of your life, then it becomes a problem. But it's not the problem of the physicality, it's the problem of the volume of the pain. And learning to turn that down. And you know how to do that because you do that in so many of your other practices, mindfulness practices, conscious awareness movement, especially forms of massage or any form of body work that includes the patient partaking in the body work, being part of it in some way so that they're conscious of the movement and what they need to do and the limitations. All of those things that take the patient on as part of the process of becoming aware and moving again. And another way of saying that, and we say this a lot, is to become friends with your body. Because one of the things that happens is that people then get caught into the process where their body is their enemy, or the body is the scary thing that's going to get them and do bad things to them. This, of course, is not uncommon in a lot of people who have been traumatized in any way. When you try to get this all together, it goes better with people that have not had previous histories of trauma or difficult lives of any sort. So people who know about resilience, who have done well in their lives, they do well in these courses. The more often people have had difficulty, the more they know about misery and pain, whatever that translates to physiologically. And we're starting to get some sense of how that works inside a person. As we get an idea of how that works inside a person, it's not very different to what happens at the cellular level with pain. And in fact, it may be that going and looking at the really basic research of pain, we may be looking at the same mechanisms we're dealing with highly distressed people who are reliving their tortures, reliving their extreme experiences, or other people who are basically defining themselves through that because they have no other way to define themselves. And so they need their distress, their pain, their stories and their horrors, because without it, they can't find who they are. They don't know how to work out who to be and how to be what they be. And this is all about, as you know, all the things that you talk about generally in your programs as a whole. No different in pain. The thing that is different in pain has to be included. It can't be left out, and you must always look as though you are there specifically to work with the pain. And by the way, this will contribute and this would be part of, and you need to take care of this as well. And isn't this similar to, and doesn't this look like part of, right? And so you pick them up together. You do this integrative work with people that need integration. But lots of people do not want it. They don't want it because when they come to see me as the doctor, they're looking for a switch. And if I'm not going to give them the switch, and I'm going to ask them at some level to be self-referent, self-educated, self-aware, if I'm going to ask them to do that, they're going to be saying very naughty words to me. And in saying those very naughty words to me, will walk out of the room and say, but what I really wanted was a lot more narcotic, because I believe that narcotics will make a difference to me. So that argument is very common. We have that over and over again. And mostly over years, that argument breaks down because people get it over time. They educate themselves. There's lots of places in which people can get education about pain. New South Wales has a lot of pain resource centres. There's a lot of stuff to read, lots of stuff to look at. There's really great online stuff, and there's also online pain programs that people can do. And that's before we get into the more the deeper stuff like the somatic processes and those other things like that. So if we are dealing with what we are suggesting is that one of my mentors, Milton Curran, who's a professor, talks about pain as being one of the phenotypes, that PTSD is one of the phenotypes, tortures and terrible things, anxiety is one of the phenotypes, dislocated family is one of the phenotypes, and pain is one of the phenotypes. And underneath it all run by the same system. And no matter where you start from, you're going to need to get in underneath all that to the degree to which the patient is ready, willing, and able to do that. And of course, most of our patients are not. Most of our patients have got their blinkers on. And one of the reasons they've got their blinkers on is because they've got a disorder that creates blinkers. The things that create blinkers are anxiety or fear and pain. That is, the alarm processes create blinkers purposefully because they want you to pay attention to that pulling your hand out of the fire. They want you to move away from the scary thing. They don't want you to sit there with the tiger in the room and say, pretty tiger, nice teeth. They want you to get out of there as quickly as you can. They don't want you to sit there with your hand in the fire and say, this is fascinating, this really hurts. I'd like to see how this goes. That's not what pain is for. That's not what fear is for. It's to immediately move you away from the process and try and protect you. But when these things become more than what they were meant to do, because the system itself has now generated a self-replicating process inside. And these self-replication processes are fascinating and interesting. In chronic pain, it's not just what happens in your head, it's also what happens in your spinal column. So for example, you're sitting on whatever you're sitting on right now. Now, you weren't noticing that. That wasn't talking to you in any way. When I said you're sitting on something, all of a sudden you became somatically aware that you're sitting on something. You always had those things firing. Those pieces of information were not getting through your spinal cord into your cortex. They weren't going anywhere. But the moment I said you were sitting on something, then all of a sudden they went into your spinal cord. Through your spinal cord, all the way up into your cortex, and you became aware. So we know these things are happening, but all of a sudden it's what you do with the change in your awareness that creates this. And that change of awareness can happen in the cortex, any part in your brain, all the way down your spinal cord, but it can also happen right at the periphery. So there are, even in some disorders of chronic pain, you see changes in skin, changes in hair, changes in colour. These complex regional pain syndromes, as they're called, really dramatic to look at. And the patient will hand them up to you and say, see, it's real, it's real, it's real, you know. And what they mean from that is it's yours to fix. And we never think it's not real. Of course we think it's real, because we know that this is a phenomenon that is absolutely true for the people that are having it, apart from the ones that want to pretend to have it in order to get their drugs and whatever. Those are, but the ones that are really there because they are in pain. There is no argument about the truth of this, no argument at all. What there is now a complex way about going how to treat it. And that process requires the patient to get on side with the idea that this is a process, a time, and it takes a while to learn how to do it. And you'll do it in steps, and doing it in the steps, you'll go up and you'll go down. You'll have good days and bad days, and all of that sort of tolerance stuff that we teach all our patients in the way, in what we do. So that's my half an hour's worth, minus 59 seconds. And I don't think I know anything else to say, but maybe I do. The other thing to say is that sometimes surgeries are helpful, sometimes individual medicines are helpful, not as commonly as we would like by far. And if they are helpful, they should be used. But if they don't work, they should be withdrawn, because they all have side effects, and they have side effects over time. All right, so now I've done my bit.